Okay, so we are here with Ebonie Rio today. Hi, Ebonie.
Hi, thank you so much for inviting me.
Oh, thank you for coming on. It's a real pleasure to talk to you. We are looking forward to talking to you, and we've already got some questions lined up for you on tendinopathy. But I was wondering if you could just start off by just letting everyone know, for those people that haven't come across you before, letting them know who you are and what you get up to.
Sure. So I am physio trained and completed my PhD with some amazing people around me. So I was interested in tendon pain. So I was very lucky to have Professor Jill Cook, Professor Lorimer Mosley, Craig Purdom, just brilliant people around me. And I'm now I still work clinically as a physio. So and I'm also doing research. So I'm employed at the Trobe Sport and Exercise Medicine Centre, which is based in Melbourne in Australia.
That's a real nice set of mentors that you've had through your PhD. Have you completed your PhD now?
I have. It's all completed, submitted, and I've worn a baggy cap and had a piece of paper handed to me. It's all official.
Excellent. And just tell us a little bit about your PhD and what you did for your PhD.
Sure. So we were very interested in looking at tendon pain from a perspective of completely outside the tendon. So, as everyone will know, we've got this disconnect between pathology and pain. So, people can have, pathology in their tendon, but, no pain or vice versa on occasion. So, we were really interested in looking at how the central nervous system and in particular the motor control might change if people have tendinopathy. So I specifically looked at patellar tendinopathy, and we use some imaging techniques to look at the motor control. And the motor control is really broken down into excitability and inhibition, if you like. So if you think of the brake and the accelerator on a car, everything we do is a balance between that brake and that accelerator. And using these techniques, we can look at both of those things. So my research was, first of all, looking at differences in the excitability and inhibition in people with patellar tendinopathy and those without. And then, interestingly, we found huge differences in people that had pain from their patellar tendon compared to people that had no history of pain but still did a lot of jumping. So then I really got very excited about the neuroplasticity literature. I wanted to see, well, how can we change this? Is our rehab doing enough to address these changes beyond, strength or beyond what we think we might be doing at a tendon level? Do we really need to have a better appreciation of manipulating that brake and the accelerator to maybe improve our outcomes for people with tendon pain? The second thing was also, can we, as clinicians, what can we do to reduce pain outside of those invasive interventions like injections?
And great. So thinking about that, with your research, do we have an understanding of why some people have pain and some people don't?
Oh gosh, that's a great question. The short answer is no, we don't. It's really fascinating. People can have, pathology that is significant enough to go on and rupture, and they've never had symptoms. In fact, it's more common that they've never had symptoms, the people that end up rupturing. So, potentially that pathology occurs in an area that isn't being sensed by the nervous system for some reason, and we know that the nerves seem to be limited to the outside of the tendon. So perhaps, that it occurs away from, the paratendon or the outside of the tendon, and it's kind of going on a bit unchecked, but we're not sure. And the whole issue around pain is, it is very much modulated by, the central nervous system, and it's an output. And even those that have pain, some people, cope much better than others, and that's true in a number of conditions. So why some people have pain and others don't remains a mystery.
Okay, so there's no sort of pathological reason, no sort of peripheral mechanism that can explain that.
One of the challenges is, we talk about the disconnect between pathology and pain, and I guess when we're saying that, we're talking about imaging, or we're talking about pathology we can see. So in terms of what we can look at, using methods like ultrasound or MRI or even ultrasound tissue characterization, we're talking about larger things like collagen and all of those things and those bundles that we can see. What we can't see are substances and receptors and even nerves. So we have no capacity at the moment to understand what's going on at that local level and what seems to be driving that nociception, that input.
So I guess what we really have to be thinking about when we're dealing with individuals with tendinopathy is that some people get pain and some people don't, and we don't understand the reasons for it, and we just have to accept that.
That's a pretty good summation of the state of play. So when we're talking to people about tendinopathy, we go through, we probably know a lot more about what we don't think is related to, driving tendon pain. So we talk about, the things that have been, somewhat disproven in the research in terms of driving pain. And we know a lot more about what doesn't than what does. So what we tend to do is say, well, we don't have a great understanding of what's driving it, but, what can we do to change it? We sort of move past step one.
Yeah. So moving on then, what can we do to change it?
Well, one of the most effective things that we can do as clinicians, and I'm sorry about the train in the background, is I'm doing laps around the block. One of the most effective things, and many people will be familiar, is really heavy isometric load. That works really well on a number of levels. So Jill Cook and Craig Purdom have been, using isometrics clinically for a long time. And one of the things that I was really interested in is it something about isometrics that's different or special, or is it just a form of exercise-induced hyperalgesia? So there's some great research looking at using exercise for pain relief or analgesia in a number of different conditions or even normals. So they look at things like, doing a bike ride or doing different weights, and they use different methods to look at whether or not exercise itself has some sort of analgesic effect, and it does. So my interest was, is there something about isometrics that's different, or is it just because we're getting them to do load? So that's how I set up my second study of my PhD, was to compare heavy isometrics and heavy isotonic or concentric eccentric, and to match them exactly for, time under tension and all of the things, so that the only difference in those two conditions was the type of exercise contraction, and that way we could really answer that question. So in terms of that study and what we found is that heavy isometric load significantly reduces tendon pain. But the other really cool thing that we found using the brain imaging techniques was that heavy isometrics also significantly changed the inhibition or the brake. So what we can do is we can use isometrics, before games and training, because if we take the excess brake out of the system, they were actually 19% stronger. So we're not sending these athletes into an environment with impaired muscle performance. In fact, it was improved. So we use isometrics confidently in our athletic population, before games and trainings. completely anecdotally, I don't have any research for this, we're using it before weights. If we can reduce the inhibition, maybe we can actually access some of the strength better. So we'll use it pre-weights. And even in our non-athletic tendinopathies, we're using it for not only pain management regularly throughout the day, but, in our occupational population for pain relief for our, less active people, and even in terms of occupation, because we know that it doesn't reduce their muscle capacity. If we can reduce their pain, we can get them to do it throughout the day at work, your tradies or people that have tendon pain associated with their work, and we know it's not going to impair their performance. So we use isometrics to control pain in a number of different clinical settings. Now, the other exciting thing about that research that we also followed up on was that isotonic exercise didn't make people worse. So what we have are two forms of exercise that were well tolerated in people, but in terms of immediate pain relief, so bang for your buck, isometric exercise reduced pain significantly and more than isotonic, and also had the effect on inhibition. So it's a really great clinical tool.
So when we're using, so let's think about this. So if we're using isometrics to reduce pain, what sort of stage of tendinopathy are we using this in? Can it be any stage, or are we sort of thinking more about the reactive stages?
Great question. So what, as best we know in terms of staging the tendinopathy and the clinical presentation, we think that the clinical presentations are the reactive ones, and then the reactive on degenerative, the ones that have a flare-up in the normal part of the tendon, and that underlying pathology, which is a very, very common presentation. So when people say to me, when do you use isometrics? My response is, usually people are coming to see you with pain. That is the most common clinical presentation, and so they probably fit into one of those two categories. Now, I've got one exception. I have had one lady come and see me because she didn't like the look of her lumpy Achilles in high heels, but everybody else seems to come when their pain is flared, either for the first time, like the reactive tendons, or those, those acute on chronic, those more grumbly ones that just get tickled up every now and then. So from the clinician's perspective, the person coming through the door is usually presenting because they've had a flare in pain. So we will often use isometrics as a first line because most people are coming with pain.
Okay, so isometrics in the reactive or reactive on degenerative stage are effective. So, and what about isotonics? Just before I go on to the other question that's in my head, what about the isotonics?
Yeah. Great question. So it's really important that everyone understands that we don't stop with isometrics. That's a strategy that we use to address pain. It's a strategy that's really effective for addressing the inhibition, but we move on to isotonic because it's a much more functional strengthening, and it's also going to increase the bulk. So what we'll do typically is heavy isometric load for the affected muscle and tendon, but we'll actually start isotonic loading in the other leg, but also the remaining kinetic chain. It's really important that the rehab includes every part of the unit that's going to absorb energy and release it. In terms of progressing on from the isometric to isotonic stage, there's a number of indicators, and there's certainly not recipes, but I'm really happy to help out with some general concepts. So what we're looking for is that the pain has really settled from its peak. So if someone comes to see you with, 8 out of 10 pain, you're really looking to be using isometrics to bring that down. Now, in a reactive tendon, because we've got good evidence from previous studies that Peter Maliaris has completed, along with Jill, to demonstrate that you can actually completely reverse a reactive tendon. So what we're looking in someone with a reactive tendon is to reverse that completely to normal. We can recover this tendon. So for a young athlete or a young person with their first presentation of tendon pain, you'd be looking ideally to load manage them, so to take them out of what's provoking them and use isometrics to settle their pain completely. That would be your ideal situation. In your volleyball player that's had years of symptoms, more likely to be reactive on degenerative, what you're looking to do is bring their pain back down to that kind of normal level. It's not uncommon that they would play and train with some baseline level, but you want it settled from its peak. So to progress from isometric to isotonic, you're looking for pain to be settled from its peak. There's also, some consideration of where they are in the season. Isometrics are fantastic in season to manage pain. And the study recently that we did with Matthias van Ark also showed that isotonics were really well tolerated in season. So pain is a big one, but everyone's got to make sure they move on from isometrics to isotonics once they're able.
Yeah, I think that's really good. That's a really good give some good guidance for how to progress from isometrics to isotonics there, and when to use the isometrics as well. So I'm just thinking about, so your work's been on patellar tendon mainly. Can you just really quickly give us an example of some of the isometric exercises that you have been using for that?
Absolutely. So I'll tell you when it's something we've researched, and I'll tell you when it's something it's clinical, because it's important that everyone understands that not everything has published evidence yet. So I'll be really transparent about that. Now, if we consider the patellar tendon, we've published the leg extension machine, which is fantastic because you can increase the weight, because this needed to be a heavy exercise and heavy relative to what the person can do. So the weighted leg extension machine in about mid-range, so not completely straight, knee not bent to 90, somewhere in the middle. We've published that in both a immediate effect, and also that's the intervention that we used in our in-season randomised controlled trial. We've also about to submit a paper using the Spanish squat. So the physio's name, I believe, is Garcia. So it's a wonderful exercise. It's a belt that goes around a pillar. And the fantastic thing about this is people can squat backwards with their tibias at 90. It puts a fantastic load through the quadriceps and an isometric load through the quadriceps and the patellar tendon. And the reason why we investigated this exercise is people were saying to us, we don't always have access to a leg extension machine, particularly if we're a traveling athlete, tennis, for example. We don't know what's going to be at the gym when we get to, whichever tournament. So we're about to submit that paper, and we showed that reduced pain and was efficacious in season. In terms of other tendons, there's no research. I'm happy to share what we do clinically. In the Achilles, we've got two options. We can either do a seated calf raise. Ideally, that's again with a machine because you can weight it. If you try and add weights, on top of the thighs, there comes a point where you can't add any more weight. It becomes too uncomfortable. But that's a really nice option for people that are a bit more sedentary and not athletic. That's a fantastic option. And another great option is the Smith machine, where you can actually get people in a calf raise or the standing calf raise machine, and you can add weights. So both of those are really good options. For some people at home, their body weight is going to be enough. So that's where people really need to use their clinical judgment and to apply a load in the clinic and test it before and after and make sure that they're giving a protocol they're happy with. In terms of, hamstring tendon, the prone hamstring curl is fantastic because the hip isn't in flexion, so you don't have any compression of the tendon over the attachment. So, the key things that we're looking for in an isometric exercise is that there's no compression and that we can apply a load and, that there isn't so much muscle shaking that it's no longer isometric. So you want it to be heavy, but you want it to be a load that they're able to do and that they're able to hold.
That's really useful. Thank you very much for those examples. So moving back to the people in the reactive stages, they come to you with pain. What about the people that actually can't tolerate isometric exercises?
Do you know that is such a fantastic question, and we get that question a lot. And the very first thing, and this is incredibly important, is that we have to really look at our differential diagnosis. So we often get asked, well, how do you confirm it's a tendon? Because, we can have pathology in people that are symptomatic or asymptomatic. So our gold standard for applying isometrics and then a tendon rehabilitation for the patellar tendon is that they have pain at the inferior pole that does not move and does not spread and is associated with high tendon load. So we're looking for, jumping, change of direction, those sort of activities, not walking or riding a bike. So we have criteria that, is well published in the literature in a number of different papers, and there are two criteria for tendinopathy: localized pain with a dose-dependent increase in tendon load. So Sean Docking and Jill and I recently published an editorial in BJSM about, the diagnostic dartboard and does a pathoanatomical diagnosis matter? And, I'm very much of the opinion that if you have vague anterior knee pain that moves around, I don't care if you call it Fred, don't treat it like a tendon. So what we're really looking for in terms of applying these principles are people with those clinical features. So the first thing we always look at when people say, I've tried isometrics, they didn't work, is we go back to their diagnosis. Do we think that the tendon is what is driving their clinical symptoms? Jill and I see a lot of patients together. They've often been misdiagnosed with patellofemoral joint or whatever else. And that is a really, really key clinical marker for people. So localized pain associated with high tendon load. So it's important we all know what high tendon load is for each tendon. And, walking and cycling is not high patellar tendon load. So if someone has pain with those activities, really go back to your diagnosis. The second thing I'll say is look at what they've done for their isometrics. So again, we've had people say, I've tried isometrics and they didn't work. And often they're quite extremes. They've either had, they've been asked to just squeeze their quads. Well, that's nowhere near enough load to help with tendon pain based on the pilot research we did. Or they've done, 250 kilos on the leg press. Well, that's probably a bit too much. So we look, first of all, at their diagnosis. Second of all, we look at how they've done it. And we go from there, and we're very much using heavy isometrics as part of our differential diagnosis. So we are confident that heavy isometrics help tendon pain, but it's heavy for that person. You have to get the load right, most importantly, you have to get your diagnosis right. If you get someone with patellofemoral pain in the Spanish squat or on the leg extension with 70% of their max, they'll hate you. They'll get off worse.
So I guess it's important to identify that it's the tendon that's driving the pain, and then obviously looking at what they're doing, but getting the loading right. So is there so if you are, if you have established that the tendon is driving the pain and you're doing isometrics, but they're still being exacerbated and they're doing their technique right, but maybe would it be the case that you have loaded them up too much and you would reduce their load?
Yeah, there'd be definitely things to consider. And one of the things would be is to look at everything that might be contributing to the clinical picture. So if we take the Achilles insertion, for example, do you need to get them in more of a elevated shoe to get them out of compression, or are they stretching? Is there something else that they're doing that is continuing to make this tendon grumpy? Now, we would certainly play around with load and all of those things. But one of the things that I often see, Rachel, is that people are a bit scared of load, and the first thing they'll do is actually back off. Now, if your load is really heavy, that might be appropriate, but more often than not, it's something outside of your isometrics, because isometric exercise, so a static hold or even isotonic heavy slow resistance, is not high tendon load. So high tendon load is anything where you're asking the tendon to act like a spring. So those exercises really shouldn't exacerbate a tendinopathy. And there's obviously exceptions to that if the load is ridiculous or if someone's doing it too fast or in compression, all of those things. But isometric exercise, and even moving on to that isotonic, is not heavy for a tendon. It's heavy for the muscle. It's very heavy for the muscle.
I think that you've made that really clear. That's a really good answer.
And I'm sure I'm going to get beaten up on Twitter because someone will take issue with, it's hard. I want to be helpful, and, there's no recipes, but yeah, I hope that's helpful.
No, that's exactly what I was about to say. There isn't a recipe, and people need to use their clinical reasoning, because each of their patients, each of the people that they see is an individual, and everyone presents differently, and everyone has so many different things going on. So it's really unfair for me to say, ask you for a recipe. And I think, it's really important that people understand that they, listen to you and take on board the knowledge that you can share, but then use that in their clinical reasoning for the individuals that they see.
Can I give you a great example? Jill and I saw a lovely lady with a long history of really incredibly painful insertional Achilles tendinopathy, and she'd had a number of treatments and injections, and really, that's a bit irrelevant. She was incredibly sore, basically. She was in a cam walker, so she wasn't loading that at all. And that would have been completely inappropriate for us to give her, a Smith machine standing on one leg with, some sort of percentage of her body weight. She could barely do 5 kilos on a seated calf raise. So we talk about heavy isometrics. Well, that's heavy for her. That was a tendon and a muscle that had been unloaded and deconditioned. So we talk about heavy, but it's clinical reasoning, and it's about listening to the person about the loading that they've done. And, you might need to take that right up to very heavy weights on a Smith machine for an elite football player, but it's very much a clinical reasoning process.
Yeah, excellent. I think that's a really nice example, because you do tend to forget about those people who you need to really lower it down for. So clinical reasoning, really important.
Yes.
Yeah. Okay, so I have one more question. So I think we've covered a lot on isometrics and isotonics. Is there anything else on isometrics, isotonics in your work that you would like to share, or you think we haven't covered?
Can I add just a little something to maybe tickle everyone's neuroplasticity senses? So there's some fantastic research that has been completed by lots of different people, but I'll just highlight a few. So Mike Luong and Dr. Dawson Kidgel, among others, have looked at strategies that are capable of changing the excitability and inhibition in our motor system. So we used to look at, so if you do a skilled activity where you're really concentrating on something, so you might be moving your finger back and forth, copying something on screen, you actually get this ton of plasticity and this huge change in excitability and inhibition. And if you do a strength exercise, and that is, sending someone off to the gym and telling them how heavy and telling them how many or how long to hold for, you actually don't get changes to excitability and inhibition. Strength training and the way we currently prescribe strength training does not change that brake and accelerator. So what these guys have done, and this is really cool, is to put a number of different conditions against each other to demonstrate exactly that. And what they found is if you externally pace strength training, so if you use a metronome so that you've got an auditory cue while you're doing your isometric hold or while you're going through your concentric eccentric contraction, not only do you have, the exact time under tension and all of the muscle things that are important, what you actually do is change the excitability and inhibition. So you actually change your brake and accelerator, which we know are altered in people with tendinopathy. So the research that I've conducted in isometrics and isotonics, we've done all externally paced, and from a clinician point of view, it's really easy. You can download a metronome on your phone or get the athlete or your patient to do it, and they can actually listen to the metronome while they're doing their exercises. It's the opposite of tuning out and thinking about what you're going to have for dinner. It is absolute attention to the task. And this, for me, is a really exciting crossover of, pain science and what we do clinically and seeing if there's a way we can do what we do and prescribe exercise, but can we do it better?
That's really interesting. It's almost
I think so.
Yeah, it's like bringing mindfulness into the exercise, into rehabilitation. Yeah. Is there anywhere is there anything you would recommend that we look up to read more about that?
So there's a couple of different things. So we wrote a paper aimed at clinicians. So it's called Tendon Neuroplastic Training. And I promise you, I'm not just giving it a plug. We actually purposefully wrote it because the neuroplasticity literature is not an easy read, let me tell you. So that paper, and Lorimer Mosley and Dawson and Jill, and we co-authored it. And what we did was we incorporated data that we had. So that's available in the supplementary file to demonstrate what we're talking about. But what we did for clinicians was try and put all of this stuff together to say, what do we think about this? And is this an area that we should be considering? And, this is a really early concept in rehabilitation, and we're excited about it being a potential avenue to improve our outcomes, because at the end of the day, there are a lot of people that aren't better with what we do with our tendon treatment. So, we need to find ways to get better.
Yeah, that sounds really interesting. It sounds like that could easily extrapolate onto all areas of rehabilitation as well. So it'd be interesting to watch that space that you're working in.
I think so, and one of the things that I think is going to be really cool is, you're possibly going to get different changes to the brake and the accelerator depending on what is driving those symptoms. And so the very first study that I did in my PhD was to look at whether or not it was just pain, or was there something, again, specific about that focal or that diffuse pain. So again, I don't care if people call it patellar tendinopathy or not, what we looked at was if you had pain at the inferior pole with, those energy storage activity versus vague anterior knee pain versus control athletes that jump the same number of times per week, what did your accelerator look like? So we did our brain imaging to look at that excitability, and we found that people with patellar tendinopathy had huge amounts of excitability. They had a completely different accelerator, like their foot was stuck on the accelerator. Now, people with vague anterior knee pain, and included in that clinically, you'd think of patellofemoral pain or fat pad or all of those things, that vague anterior knee pain, their excitability was no different to controls. So there's something about not just pain, but there's something about those peripheral structures that might be associated with different changes to our brake and our accelerator. So not only is that kind of pointing towards our clinical reasoning of the kind of source of symptoms needing to be important, but our rehab needs to be quite different. We need to, really finesse what we're doing for those subgroups, and not subgrouping by pathoanatomical diagnosis, subgrouping by clinical features, and putting people together and putting them on a pathway that they're going to get a good result.
I feel like I could listen to you talking about this all night, all day, Ebonie. There's so much.
Sorry.
No, it's fine.
Can you
There's
say
lots
that
of great
again for me?
information coming out, but I'm really aware of your time. Can I just move on to the one last question that I have for you? And I was now, we use isometrics and isotonics and this new information that you've just talked about on neuroplasticity and techniques to incorporate that is really, really interesting. And I know that's the most effective way that we should be, most effective thing to be implementing into our, including in our rehabilitation strategy for tendinopathies. But I'm just wondering, are there any other adjunct techniques out there, modalities or anything that you would recommend for treating the pain in a tendinopathy?
Yeah, that's a really good question, and I'm worried I missed some of it because you dropped out a little bit. So if I missed the mark on the question, please redirect me. So one of the things, I think tendon pain is there for a reason, and I think it serves a physiological sort of tissue protecting, purpose. It fits with it being a nociceptive condition, so linked with load. Even though it's chronically nociceptive, I would still argue that it has a nociceptive driver. And just because we don't know what the nociceptive driver is, and that's true of many conditions, doesn't mean it's not there. Now, we see a number of sensitization of tissues associated with nociception. You see it when you roll your ankle. There's a great study in lateral ankle sprain looking at hyperalgesia on the other side. So I would be reluctant then, if we think clinically, I'd be reluctant to do anything that just wiped out pain. And I know in the past people have, tried local anaesthetics and the sort of things that completely mask pain. What I think is really reasonable to do is use techniques that can modify pain so that people are capable of doing their rehabilitation. Now, in the athletic environment, often people are modifying pain just to be able to perform, and I understand that, and I work in that space, so I get it. So the things that I would consider to be really reasonable are things like our triple therapy, so the ibuprofen, the doxycycline, and the green tea, because not only, will they have a pain, an effect on pain, and because they're analgesic, but they appear to, potentially modify the disease process and have a positive effect on the tendon, not just mask pain. So that's not a bad go-to for people. People often ask me about shockwave, and the jury is out in my mind on whether or not it has a potential negative effect on the tendon. There are animal studies that demonstrate that it could actually disrupt tendons. So until we know what's going on in humans, I think we shouldn't just be shockwaving everyone. I think there should be some sort of consideration around it, but we think that of all adjuncts, obviously. So it's 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 difficult. There aren't a lot of things out there, and I think that's why people have been really excited about isometrics, because it's something that people can do for pain that isn't detrimental or just masking it. It's something that's a positive part of their rehabilitation. And, it also is exciting for people that they can do something themselves that's not an external treatment. There's some exciting new research coming up that might be understanding the nociceptive drive better, that might give us some more options. But at this stage, we have very, very few things that just change pain. In tendons. If anyone's got any, I'd love to hear them.
Yeah, I think that's really useful to hear you talk about that. I had one person ask me to specifically ask you, what about glycerol trinitrate patches?
Yeah, that's a really good question. People got really excited about them a few years ago, not just for their effect on pain and being able to put them on while they exercise, but also for potentially having an effect at a tendon level. I think for me, you have to look at the longevity of something in its use. That's probably a good barometer for where it's at. Everyone got very excited about it. Hans Werther and their group did a fantastic placebo-controlled trial and found no difference in the patella tendon. So it's definitely worn off. But like all adjuncts, they potentially have a place. We're treating at the coalface for the clinician, we're treating the individual, and it's often really difficult looking at the randomized controlled trials or looking at the body of literature and applying that to the person in front of you. So what I would say is sometimes we try those 1%ers, but what I wouldn't want people to do is try and add all of those up. So Jill talks about the wheel of tendons, and the wheel of tendons is that the guts of it, the hub, is really that 70 plus percent that is the capacity of the tendon and the kinetic chain, and all the bits, all the wheels and the spokes around it are the 1%ers, the glycerol trinitrate patches, the medication, the massage, the orthotics, the shockwave, the whatever it is. And what we often see is that people have tried to add those up, and that will never add up to a significant benefit. And often people come and see us and say, I've tried everything. And what they've tried is all the adjuncts. So adjuncts that allow people to do their rehabilitation are okay, especially if they aren't damaging for the tendon. That we don't advocate those because we try and respect and restore what the tendon has in terms of its tissue. But if sometimes we are clutching at straws, but we shouldn't be going to those things first, or relying on them, or expecting them to be a magic bullet. There's no magic bullet.
I think that's a really great that's a really great description of how we should use adjuncts in individuals with tendinopathy. And again, it comes down to clinical reasoning, doesn't it? And looking at the individual.
Sure.
Yeah. So using adjuncts to enable people to do their rehabilitation exercises, their isometrics and isotonics, to make the big difference. Really, yeah. So is that a fair summary?
I think that's a good summary.
Yeah. So really, really nice to speak to you, Ebonie. You've that was an amazing wealth of knowledge that you've shared with us. Is there anything else that you'd like to say to people that might be listening? Any other messages you'd like to put out?
No, I don't think so. Just it's great that people are so excited about improving, how we might treat tendons, and that people are constantly asking questions and challenging the researchers, and that's really exciting. And I think we should all try and do that, and keep striving to be better. We don't have a gold standard, and we treat tendons a certain way, and we get great results clinically, and we're looking to investigate that in a more research capacity. But we should all be trying to do better for patients. And yeah, I congratulate you for pulling this all together with the people you have. I think it's great information for people.
It's really nice to be able to talk to you and share your knowledge with people. So we're really looking forward to your future work. It'll be really interesting to see what you publish and come up with. Whereabouts can people find you, more about you online? So I know you're on Twitter. I think you're at Tendon Pain, is that correct?
Yeah. So Jamie Gator, I'm so not technological, and Jamie Gator put me on Twitter and made my Twitter handle, and I can still barely tweet, let alone put a photo up. I'm really bad. So if I'm bad at getting back to people on Twitter, I'm a technological, dimwit. So.
That's fine. That's totally fine. So you are there, but you're not engaged, and it's not necessary to be engaged on Twitter these days. Just some people are. Is there anywhere else we can find out about you and your work?
If you look up the La Trobe Sport and Exercise Medicine Centre, they've got a new website which has gone live, and we've all got a little profile on there. But more importantly, there's a link to all of our publications, so you can get on there and sneak through and get Jill's and get Sean Docking's stuff, and click through mine and link that through to Lorimer, and so that's quite a nice little place that you can access some great stuff.
That's perfect.
And actually, what they're going to do, and this is really cool, they're going to start blogging some different things, and it's not just tendon. There's a number of different researchers in the centre, but they're going to be blogging about patellofemoral pain and just the latest research. So that's going to be a really useful, free little place for people to get cool tips.
That's great. We'll definitely share a link to that when we
cool.
share out your audio, so that people can find out more about you and often follow you from here. So thank you very much for talking to us today, Ebonie. It's been amazing to listen to you. I hope you've had a nice walk around the block while you've been talking.
I have, and thank you again for the invite. I'm really flattered. So thank you. That's lovely.
Okay, thank you.